renal cell carcinoma will come as a theoretical question, will come as a long case, will come in as a short case, will come in your specimen test, and also in the radiology, CT scan, and all these things. So even if you are not a urology resident, as a general surgeon resident, as a surgical oncology resident, or even in your MBBS final exams, you are having a very high probability of getting a case of renal cell carcinoma. And renal cell carcinoma is very common in our practice. So I will prefer the way I will present today's case, it will be a case presentation sort of, because in this because that's why I just told I will be running a monologue to begin with. The monologue is I will be acting like a student and I will be acting as the examiner also. And these are the points you have to keep in mind while taking a history. Now, it doesn't mean that I am going for a renal cell carcinoma history as per se, but this is a normal history. You will see a patient, you take a history, and the history can be short if you have a short case. It can be long if you have a long case, and these days in DNB you have a longish, shortish cases. So you have to modify it's a template. You have to modify it accordingly. The basis of taking a history is that you get to understand what you are dealing with, and you have to channelize your history points towards a diagnosis. Ultimately, you give a ultimately give a differential diagnosis, and then give a provisional diagnosis. I'm not going into all this how you do it. It's already covered. So I am presenting a 45-year-old man without comorbidity. He has pain in his right flank, which is dull aching. Now you have to characterize the typical points of a pain. Specifically, if you're talking about a right flank pain, you're basically dealing with a kidney problem. So it's a dull aching, intermittent, that is episodic, non-radiating. But that's very important. If you have a loin pain, and you have to comment on the radiation of the pain, because a renal pain can be a fixed renal pain, which is due to most likely to a renal in origin, or it can be a pain due to any obstruction in the ureter, which can have a radiation from loin to groin. Right. So it's responding to analgesic medicines and with no aggravating factors. So it has a relieving factor. No aggravating factors. It has no relation to voiding. So what is this important points are? Because now, very important, if you have a loin pain and if he has any relation with voiding, then you are basically you're trying to maneuver your case towards a benign cause of hydronephrosis, most likely due to pH obstruction. So basically, you're building the case and you're trying to channelize your history towards your own provisional diagnosis. He has hematuria. He has 2 episodes of hematuria, which is gross. Gross and total means significant hematuria. Patient may have very intermittent hematuria, or it's the first part of the urination, or it can come later part in the urination. And later part of the urination is most likely due to the bladder neck causes. And the first part can be due to bladder neck and can be due to even upper tract. So it's a vague. Early initial hematuria is vague. So gross hematuria means he starts the urination. The blood in the urine is present right from the beginning to the end. So a gross total hematuria, and then it's becoming important is a painless. Now this is very important. If a person has hematuria, you have to say whether it's a painful or a painless. Because when you say it's a painful hematuria, you are more likely taking the patient, your diagnosis towards an infective etiology. Because if he has infection, if he has inflammation, if he has cystitis, that is the inflammation of his bladder, prostate, whatever, lower tracts, then he will have pain with hematuria. You have a dysuria with hematuria. But a gross, total, painless hematuria signifies towards a malignant etiology. Now the last part is also very important. It's associated with serpentine clots. So whenever you say gross, it means it is associated with clots. And clots, it's better if you can mention the shape of the clots. Serpentine clots means it is coming from the upper tract, the ureters. Because what happens in the kidney is that there will be clot formation, but it will come to the ureters. Right? It will break and come to the ureters. So that's why it becomes a long sort of a string-like clot. Why if there is a bladder cancer, the patient has a clot, they are more likely to be flat, rounded clots. You can understand. Whenever you have serpentine clots, you are again trying to maneuver the history towards the upper tract. So from this history, you have a middle-aged man without any comorbidities. Obviously, he has no significant occupational history. He has pain and he has hematuria. So the examiner will ask the student, what are your provisional or your differential diagnosis from this simple, the first part of the history of taken. So if the student says, sir, we are dealing with a renal cell carcinoma, then most of the chances that the examiner will know that you have known your case. You might have known your case. You might be very intelligent, even if someone not has told you what's the diagnosis of the case. You're basically deciphered it from the very beginning. But try to act that you are going in a stepwise fashion. The first diagnosis which will come to your mind, right, with pain and hematuria will be whatever the cause is a stone disease. So talk about stone disease, talk about infection, and try to bring in malignancy down the order. Then you will go to give father positive history, father negative history to channelize towards your provisional diagnosis. The first thing comes in our mind is stone disease. Right. So now is the important negative history you have to take in your protocol. So because you're thinking about stone disease, you have to rule out any past history of stone disease, kidney stone disease, urethral stone disease, to be specific. Because whenever you say that he had a history of a kidney stone or urethral stone which was treated medically 2 years back, then he had another recurrence which did a surgery, you are trying to push your diagnosis in favor of a stone pathology, stone diagnosis. So this is important. Any form of surgery, say about that. Now, another very important diagnosis which will come in your differential diagnosis is the renal trauma, because patients may forget that he had one renal trauma, but then he may present with hematuria and a pain abdomen. So always think about, always take the points in that order, whatever in that order or different order, but try to remember negative history is also important in your history. Not only positive history, negative history. You can write it as such, you can make a template of yourself and write it down 1, 2, 3, 4, 5, 6, or you will try to put them in order to channelize your history towards the perfect diagnosis. Very important is the lower unit tract symptoms. So what are the lower unit tract symptoms? We will discuss. It's called the LUTS. We'll discuss it when we are talking about prostate and the bladder. These are basically obstructive symptoms and irritative symptoms. Just take a question. Do you have any problem in passing your urine? One, that's obstructive symptoms. And do you have any problem in holding the urine for long? That's the irritative symptoms. So a person can have hematuria, can have pain abdomen, and can have significant LUTS. So you have channeling your history again in the direction of a lower tract etiology. So all your history, from the history itself, you are focusing on your diagnosis. UTI, that's urinary tract infection in past history of because the first thing came up of mind with a painful dysuria plus hematuria will be a urinary tract infection. If you had a previous history, try to mention. So any history of fever, anorexia, weight loss. And these are important constitutional symptoms. Remember, nausea, vomiting can come in colic. Yes, it's very important. Whenever a patient has a ureteric colic, he will have pain, he will have an episodic pain, he can have hematuria, and he can have a nausea, vomiting associated with it. It's all due to the traction of the nerves. Now, and also the expansion of the renal capsule because of the swelling. Now, constitutional symptoms are increased in patients who are suffering from a malignant disorder and an infective disorder, chronic infection. Try to remember any patient with a pain, even the hematuria, and all these constitutional symptoms, you will have a tuberculosis or genitourinary system as your differential diagnosis. But still, examiners prefer if you have a tuberculosis as a differential diagnosis. So then we come to the talk about the metastatic symptoms: cough, chest pain, and body pain. You take a history, it may be negative, just forget to take the history. There's no history of cough, no history of chest pain and body pain. Now you can omit many of the non-significant negative history if you're taking a short case. But this is a template. This is a template which you have in your mind when you go for a history. Because any case, because you're thinking of a long case or a short case, it begins with your history. Very important in today's world, you take a history of anticoagulant use. Because of 45, 50 years, the person will 50% chance will having atorvastatin or any statins, and a 40% chance that he will be having an anticoagulant, ecosprin or clopidogrel or whatever. So if you miss the proper history, and if the patient actually had history of hematuria, right, and hematuria was due to bleeding or infection, which caused bleeding because he was taking an antiplatelet, and he had pain due to a clot calling, then the whole gamut of your diagnosis changes. So take a drug history anyways, but remember to take a blood. Now, this is a specific negative history which you have to take if you think that you are dealing with a case of a renal cell cancer. So basically, you have to take what significant weight loss. Significant weight loss can be anything. I mean, as they say, theoretically, it's more than 10% of the weight loss in the last 3 months, 2 months. But it's very important to understand that you have to ask the typical question, whether they had a loosening of the garments very quickly. That is the first. That's the first history they will give you. That I was wearing a 36 size shirt. Now it seemed very loosening. So that's very important because others are vague terms. So take a significant history, contact with tuberculosis, by pedal edema, because pedal edema signifies the patient has an advanced disease. Scrotal swelling, it can be anything. Scrotal swelling can be interesting, but we are basically focusing on scrotal edema, which can be due to hepatic obstruction, venous obstruction, but specifically on varicocele. Varicocele is the dilatation of the tympaniform plexus of veins, which actually drains the testicular veins. Left side, the testicular veins drains the renal vein. The renal vein is blocked by a thrombus, tumor thrombus. Is the back pressure. The back pressure causes the swelling of the tympaniform plexus. The typical uniqueness of varicocele, which has developed due to a renal cell cancer, is that it does not decompress when the patient lies down or is recumbent. So that's a typical uniqueness of a varicocele in a patient with a renal cell cancer. Left side, non-recumbent varicocele, think about renal cell cancer. Right side, recumbent, non-recumbent, whatever, the first diagnosis comes in your mind, let's rule out renal cell cancer, because here, the testicular vein on the left side, which was draining into the renal vein, now the testicular vein on the right side is draining into the renal IBC. And if the tumor thrombus going upwards, it also goes downwards, where the testicular vein actually drains. Same thing occurs. The right-sided varicocele is rare. If it is actually present and if it is recumbent, then basically your diagnosis is done. If it is not, then still first rule out the patient has renal cell cancer. So these are the points you have to hit, even though the patient may not have varicocele. Say it's a negative point, I've checked out, sir, but it doesn't have a renal cell. It's a negative history. So, and any previous surgery. Now, with this in mind, we take the secondary history, the past history and the personal history. Personal history is that he's a chronic smoker, and don't stop at chronic smoker, because smoking tobacco is the most important risk factor for RCC. It doesn't end at that. You have to talk about his number of pack years, because number of pack years, when you say he smokes about 5 packs per day or 5 cigarettes a day, they're actually talking about the risk factor burden in this patient. So whenever you say it's a 5 per day or 3 per day, will have a lesser prognostic feature than if you say he's taking 5 packs per day for last 10 years. So all these we are hitting in favor of your diagnosis. Drug history not significant, family history not significant, and always talk about no allergies. Now, before I go to our very quick system examination, this is the ECOG status many of you know better than, because you are dealing with this ECOG status of the patient on theoretical based on general surgical, because this is very common in your questions and on your clinics. But if you try to, without saying much about on clinical examination, just try to say that he has an ECOG of 1 or ECOG of 0 or ECOG of 2, the examiner will know that you, because you are made for a perfect clinician. Not going into details like he is, say that is a, don't talk to the point. He's ECOG 1. That's what I said. He's ECOG 1. He's properly oriented. He has a normal pulse rate, normal BP, febrile. Fine, done. So the general examination is actually complete. You can say yes, he doesn't have any pallor, he doesn't have any jaundice, doesn't have any icterus. You can go like this, but in a short case, in a longish short case, try to be specific. Say his back and spine are normal. You said you have done this examination and just said the bullet points. Per abdomen. Now this is very important. Renal cell cancer previously was thought to be a triad of 3 symptoms or 3 features. One was, as I said, pain abdomen. 2 was hematuria, gross hematuria or whatever. 3 is a mass, abdominal mass. It has been seen that this is basically a too late syndrome or too late triad. Previously, we didn't have so much ultrasound being done regularly for patients with gas problems. And now it is seen that most of these renal cell carcinomas are actually incidentally detected. 50% are incidentally detected because patients presented to their physicians with gas problems. Did an ultrasound, and if you start your practice, you will see gas problems. 70% patients over 50-60 years will have a renal cyst, and they will come running to you. Say we have this tumor. Most likely they will have a clear cyst that's known as a Bosniak type 1 cyst. We will discuss it later. What are the Bosniak cyst classifications? But many of them will have a renal tumor. That is when the incidental diagnosis of a renal tumor starts at 50% of the case. The rest, you can have 40% patients will present with hematuria, 40% present with, as I said, pain, only 10%, 10 to 15% present with a loin mass. And if you have this triad of pain and hematuria and a loin mass, you are dealing with a locally advanced poor risk patient. That is very important. So inspection in this case, if you have a normal general case, you have no positive finding, you've checked everything, you know points better than me. Palpation, you palpated the abdomen, you palpated the spine, you palpated the neck nodes, and you found it's normal. And for a urology examining point of view, because we didn't used to give so much focus earlier, but now any resident will have to give focus to the genital examination and if possible the digital rectal examination. Because if you're going for a urology examination, very important you mention the points. And genitally also, I'm told you some points about this. So just write down, form the template, go to the points. Now, what are the characteristics of a renal lump? Now, this is again a clinical question. This, you have to take a picture of this slide, make your own points in bullet form, and just memorize it in your brain. Whenever you have a case where you find that there is a lump in the loin or in the upper abdomen, and you feel it can be due to whatever, benign cause maybe. The most common cause is a hydronephrosis. Can be a hydronephrosis, the purity obstruction, can be due to a stone disease, obstruction causing a secondary hydronephrosis, or it can be a tumor. Whatever be the fact, you have to know the bullet points. For an examination purpose, you have to go through this exercise before you come to a diagnosis. So basically, I'm not going into details. You know better than me that what you have to maintain about tenderness, mobility to the ovular skin. You have to look for the notch. Even if you don't feel the notch, just write that I can't feel the notch on the medial margin. Mobility with respiration. very important, being an infradiaphragmatic organ, and a bimanually palpable and a palatable. Now, this is very important to say when you palpate for palatable and bimanually palpation. It is said, that's very important. It is said that first of all, before doing a loin examination or examination of renal lump, you will have to ask the patient to go to the toilet, void. You have to say to the examiner that I've asked him to go to the patient to void and then come back. It's a very common situation. The examiner will say, okay, that's done. Next, you go for that. You have seen, you have inspected, fine, whatever. And you have asked the patient that whether he has any pain in any part of the body before you examine the patient. So you are being very emphatic with your patient. This point will matter. It will discuss in your other courses. So that's very important. So there is a lot of confusion is when you palpate the kidney and how you make it palatable. When the patient take a deep inspiration, you try to palpate, but it has been said that the bimanual palpation is actually during deep inspiration and not due to deep expiration, because there are many textbooks which says that palpability must be during deep expiration. Kidney is basically it's sequestered within the rib cage. Normally, it's not palpable. You get palpable only when during deep inspiration. So deep inspiration, one hand in behind the loin and the other hand in the upper abdomen, and try to fill it in the height of deep inspiration. Again, there are a lot of controversies because some examiners do believe that it is during deep expiration, but as from my personal perspective, I go with bimanually palpable during deep inspiration. Palatability is one of the typical characteristic of a renal mass. In palatability, you are not basically bimanually palpate. The upper hand is basically just resting on the skin. With the posterior hand, you basically pushing it upwards, so they are palatable. So it's a bimanually palpable and palatable, which suggests that you're thinking about a renal lump. Now, renal angle, all this dull percussion is you know better than me. Now we come to the investigation points in this, pertinent to this. They checked your hemoglobin. The examiner may ask you why hemoglobin? Because he has hematuria, and the hematuria can cause a fall in your hemoglobin. Second, if you are thinking of dealing with the infective etiology or malignant etiology, both will cause a decrease in hemoglobin, and an anemia is a poor prognostic factor for an RCC. So one is a hemoglobin, two is a total count, again infection, malignancy, otherwise platelet count because the patient has hematuria, and again a thrombocytosis is the poor risk factor. Thrombocytosis is the poor risk factor for an RCC. Other things are normal. You do a urinalysis and do a culture because in your mind there you can have. Now there is a question whether you will do a cytology or not. A urine cytology can be done. Not routinely done, but it is not wrong if you say that I will do a urine cytology in this case, because my diagnosis will be in the favor of a malignant etiology. The examiner will ask you how do you do a urine cytology. You will say that I will ask the patient to send his urine sample in the mid morning, not in the early morning, because early morning this loss of the cells are said to be destroyed because of prolonged stay in the bladder, and they have to quickly send it to the lab, or if they can't send it very quickly, they have to refrigerate it, or if then you have to put some amount of formalin. So these are very technical points we'll discuss later on the lab features of any malignant case. So you can say about cytology this work. Next is, then your examiner will ask you next, what will you do? So you're dealing with hematuria, loin pain, and your system examination is non-contributory because we're thinking of an incidental case of a renal cancer. You say that the first diagnosis has been a stone disease, second has been a malignant condition of birth, third can be infective, whatever. So I will do an ultrasound. The ultrasound is the first investigation test in a urology. Now there will be some people who will who will make a point that because you are having a hemature in a pain abdomen, why not do a CT first? But it's my preference that if we go step by step, because ultrasound can often change the diagnosis. If it is a bladder tumor, then you have to focus the CT scanner towards the bladder more. And if it is feel that there is something in the kidneys, then they will take fine cuts when they're taking the CT. So it's always the preliminary test, do an ultrasound. So you see, because he had a pain in the right loin, so first check the normal. You always, because you are supposed, as a urology resident, you are supposed to do or read the ultrasound by yourself. But as a surgical resident, you have to just note the points you will have to ask your radiologist to give you. The radiologist is supposed to give you the important points, but you have to ask them. So the examiner will ask you, what are the points that you are asking your radiologist to tell you? He will tell you the left kidney appears normal. Yes, it's a maintained corticomedullary differentiation. The right kidney is visibly enlarged because 9 centimeters is normal size of the kidneys. It's 11.5. And there's a mass lesion with a mixed echogenicity. We're talking about echogenicity with ultrasound, and which is giving a size of 6×5 involved in the mid and the lower pole. And you see the bladder, yes, check the bladder, is normal. Right. So the next step will be a CT scan, because done the creatinine levels prior to it, it came as normal as I showed you on the investigation chart. The next investigation of choice will be a multi-detector contrast enhanced CT scan of abdomen and pelvis. This is the investigation of choice in your case. Now that you have formed your diagnosis now renal tumor, renal cell carcinoma as top in the list of your differential diagnosis. Again, the same thing. The examiner will expect you what are the points you're going to ask from the radiologist who is performing the CT. So we'll ask whether the left kidney is normal, because you're dealing with the renal cell carcinoma now. It has been more or less decided. So the first and foremost thing in your mind as a surgeon, because you are going to operate on the patient, because you know very well from your theoretical knowledge that there is no chemotherapy, there is no radiotherapy. The only treatment of choice for a person fit for surgery is surgery for a renal cell carcinoma. And since the patient has 2 kidneys and he has a tumor in one of his kidneys, you have to doubly check whether the other kidney is normal or not. Now, whatever surgery you are doing, that comes later. Whether you are radical nephrectomy, partial nephrectomy, that is the decision you will take with your team later on. But this is your case in front of you. So, very important, you have to ask your radiologist, what is the status of the other kidney? Now, coming to the status of your right kidney. And they say there's a well-defined lobulated soft tissue density, the exophytic component. Now, all these points matters a lot, right? All these points, this may seem too theoretical, too lengthy, too, you can say anything, is boring. All these points are very important, because the examiner can cross you or can basically pull you down any of these points, because you're supposed to know the points. You're not supposed to know the deep aspects of radiology concepts. But what are the questions you are going to ask from your radiologist? All these things, what is the low osmolar contrast media, what is iodine, they come very back with it. You're supposed to know only the basics. But what are the points in your investigation that will help you make a diagnosis, that will help you not to make an error, are very important. So that's the point. So soft tissue density with an exophytic component arising from the midpole of the kidney, and the pre-contrast CT density Hounsfield units 26. Right. It is talking about the size. Now the size is important when we're talking about the staging, right? And it shows a sort of calcification. Calcification again give a poor prognosis. If you have to note whether there is a necrosis or not. Necrosis, calcification, cystic changes. Cystic change is a good prognostic marker. Cystic RCC is a better prognostic marker than a solid RCC. You talk about a single renal artery status and the venous status. Whether the veins are flat or whether there is a tumor thrombus. If there's a tumor thrombus in the renal vein, then whether there's an extension of the thrombus into IBC. Especially for a right-sided tumor, a small tumor thrombus may be missed on a CT scan. So for a right-sided tumor, you have to be doubly cautious to ask your radiologist and to see by the plates yourself whether there is any tumor thrombus, taken very small cuts, which has been missed, especially for a large tumor. Now, as you can see from this specific report, we are dealing with a mass lesion, RCC, of the right kidney, which is less than 7 centimeters. So it will help you in the prognostication before you do go to further investigations. So it will stage the disease. Two, that I missed out to talk about is the Hounsfield unit post contrast. Now CT scan has, for a kidney protocol, will have a non-contrast phase where you haven't given any contrast. This is for the detection of stones in the kidney, stones on the ureter, which may be otherwise camouflaged by your contrast agent. Right. So one, non-contrast, then you inject the contrast slowly, then you take a film at 30 seconds to 1 minute, known as the corticomedullary phase. Now let me come to this picture. The one on the left is a straight film, the non-contrast film, and the one on the right is a contrast film. Why? Because you see this whitish structure going into the aorta. This is the aorta. I think we had a discussion about, Sir must have taken a class, was going to the YouTube channel about the different structures you see on axial CT scans. So if you see the contrast in the aorta and the contrast just seeping into the kidneys, this is the first stage known as the corticomedullary stage. Arterial phase is the first 30 seconds and the corticomedullary phase is the first 1 minute. It comes to 30 to 1 minute. The CM stage, the corticomedullary phase, basically the kidney is differentially lit up by the contrast, and this is the phase where you actually see the small tumors. So if the examiner asks which phase will you look for specifically, fine cuts will you take? If you have a small tumor, large tumor, then fine, it's okay. Small tumor, look for the corticomedullary phase. Nephrographic phase, actually the dye is now going throughout, first in the cortex, then in the middle. RCC develops from the epithelium of the proximal convoluted tubules which are present in the cortex, my friend. It's very important. The first in the cortex, blood comes first in the cortex from the arteries, then it flows to the middle. Medullary tumors are very rare, right? So first you take a cut section in the corticomedullary phase. Next you have the nephrographic phase, which are not shown, that when the kidney is uniformly lit up. And third is the final is the excretory phase. So the nephrographic phase, it's about 2 minutes, and the 3 to 5 minutes will be the excretory phase, where you will see in the nephrographic phase you will have the venous phase. You will have the contrast in the veins, starting to flow in the veins. In the excretory phase, you have contrast in the pelvis and ureters. This is the phase. This is the phase, you, my friend, you will have to specify your radiologist to image if you think you are dealing with a tumor of the renal pelvis, which is your differential diagnosis. In this case, a patient with hematuria, loin pain, serpentine clots, and a mass lesion on ultrasound. The patient can have a tumor of the pelvis, and basically the treatment protocol is totally different. Histology is different because RCC is an adenosine, and the pelvic tumors are TCC, transverse cell tumors, and because TCC is a field effect change, the whole diagnosis, the whole treatment protocol changes. So simply by knowing what phase of CT you will ask for from your radiologist friend, will go to the specific diagnosis. These are the points you have to know, and it will actually increase your knowledge quotient when you talk with your examiner. Right. So that's it. Next we have, when will you do an MR? I'm not going to a pregnant female or whatever. But what is very important if the patient has a locally advanced malignant disease. If the person has a thrombus which goes in his renal vein, more specifically in his inferior vena cava, better you again do an MRI. Why? Because it has been seen that a person having thrombus in his vein or IBC, 60% will be a tumor thrombus. The rest will be a blunt thrombus. Right? Patient with tumor thrombus, whether it's a blunt thrombus or a tumor thrombus, are basically best visualized if we use gadolinium MRI. Right. So the tumor thrombus will lit up. So if you're looking for a locally malignant disease, if you're looking for a tumor thrombus, if you're looking for perinephric stranding as one point which has been mentioned in your CT scan report, my friend, this is important when you talk to the staging part, because in the staging part it will tell you that whenever this perinephric spread, your stage increases. Perinephric stranding, fat stranding is a very non-specific finding on CT scan. Either you do a MRI or you depend on you when you open up the patient and then palpate. Patient with a locally advanced malignant disease will have poor prognosis when you are counseling him or his relatives prior. So this is very important. Do an MRI in these situations. Equivocal venous involvement I said about, because often the right renal vein may be compressed, may not be well seen. In this soft tissue involvement is very well seen on MRI, and if the patient has allergy to iodine contrast. Again, a very important point is a very theoretical concept. If a person is of chronic kidney disease, if the person is CKD and is having a renal tumor, better to avoid giving gadolinium in these cases, because it has been seen causes a specific syndrome known as the nephrogenic systemic fibrosis. Just remember this happened, NSF is aquatic. In this case, it's better to skip gadolinium, and because the contrast, my friend, the contrast enhancement in CT is quantitative, while the contrast enhancement in MRI is qualitative. Because I know very little about MRI, but this is very important. Even if you have a plain MRI, it serves your purpose if you cannot give gadolinium contrast in your MRI. So I talked about IBC involvement, 4 to 10%. 1 in 10%, 1 in 10 cases will have a venous involvement, and it's a very huge, right? It's a huge margin. So you have to note the points. A patient has pedal edema. I have talked about just hammering the points again and again and again, just to keep it in your mind. Non-recurrent varicocele, proteinuria, pulmonary. Now the tumor goes above. Inferior vena cava then goes supradiaphragmatic. Right atrial mass. And non-functioning of the kidney is very important. Non-functioning due to tumor thrombus. Then you're thinking about venous involvement. It has been seen that 40% of the cases there will be a vascularization of the tumor thrombus. In this case, patients having a tumor thrombus right going up to the supradiaphragmatic region or high up into the liver infradiaphragmatic, you can do a renal embolization in these cases. So these are typical points where you do renal embolization in a person of RCC. Patient of bleeding, severe bleeding from a say renal trauma, you cannot control by conservative means, you do a renal embolization. Patient having severe bleeding, you cannot control, you either take the patient, you know that the patient will die even table because there is bleeding thoroughly, then you give renal embolization. The renal embolization is stopgap. In this case, if you have a tumor thrombus, you need to downstage the disease, you give a renal embolization. It can be given by ethanol, polyvinyl sponges, all this is going to be given. Pre-op embolization of renal artery basically. And the other alternative in this case is to give you targeted therapy. Target like sunitinib, tyrosine kinase inhibitors will help in this case. We'll come to this. So metastatic workup is a chest X-ray. If you find any problem, the first organ to which kidneys tumor spreads is lungs. Another thing, my friend, I want to tell you is the most common tumor of kidney is not RCC. It's actually a metastasis. And the most common organ, malignancy, to metastasize to kidney is the lung. So the kidney has a preference towards lung for giving and taking. Otherwise, if a kidney spreads to bones, kidney spreads to brain, the patient will be symptomatic. But first stage of metastasis to lungs, patient may be mildly symptomatic. If you find any disconcerting finding on a chest X-ray, do a CT scan. Liver function test, do an LDH and alpha. Will come to this. What is meant by the liver metastasis? What is meant by non-metastatic liver dysfunction? Calcium. If you miss one point in your metastatic workup, please try to remember it's calcium. Calcium is very important because hypercalcemia can be caused by bone resorption, bone metastasis can be caused due to tumor per se, can be caused due to what we know as paraneoplastic syndrome. We'll come to this. So bone scan, if the patient has bone pain, if the patient has increased alkaline phosphatase, the patient is symptomatic and do a bone scan. ESR, CRP, advanced disease, metastasis will be raised. So as I talk, if you think of metastasis in different parts of the body, take a biopsy. What is a paraneoplastic syndrome? Paraneoplastic syndrome is because kidney does a lot of function other than formation of urine or filtration of urine, whatever. It is a storehouse of a lot of hormones. One of them is erythropoietin. So if the erythropoietin goes up, the patient will have something like polycythemia. It's rare. Most patients have anemia. In our setup, you can be doubly sure you will be dealing with anemia rather than polycythemia. I haven't seen a patient of polycythemia ever due to RCC. The patient can have the release of parathyroid-like peptide. If it is increased, the patient will have hypercalcemia. These patients come with constitutional symptoms. They ask you, hypercalcemia, done a calcium levels. How do you diagnose a case of hypercalcemia due to RCC? The patient have constitutional symptoms, will have decreased jerks, and you send a calcium level. Something is known as the true calcium level. Just forgot. You have to check out in the books. And you find it's high. What will you do? You have to go for post-diuresis with IV Lasix and give biphosphonates. Biphosphonates is the treatment we give in oncology setting due to hypocalcemia for malignancy. The best biphosphonate you use is zoledronic acid. You can have it. You can use it for prostate cancer, with many cancers. And the dose is 4 milligram. Is given in saline and given once a week. So persistent pyrexia, PUO. The patient has fever, constitutional symptoms, anemia, hypercalcemia. Now renin is also produced. Hyperexcretion of renin can cause hypertension. No cause. Give him olmesartan. You give him different antihypertensives. The patient is not controlled. And you even do a Doppler. See the renal arteries are normal. The patient has this paraneoplastic. Stoffer syndrome. Very fancy name, but the examiner loves to ask about Stoffer syndrome, and it can come as a short note also. It's a non-metastatic hepatic dysfunction. Here, there will be disarray of your liver enzymes. It has been found in biopsy there is no metastasis but hepatic necrosis, and these patients do very well after you remove the kidney. That's called a Stoffer syndrome. So next we come to the risk factors. Talked about smoking, obesity, hypertension, specifically in females. Females have a low risk. It's about 2 to 3:1. Some risk is there. Occupation, the person is working in agriculture industry. Herbicides are found to be a risk factor. Penicillin abuse, historical aspect. Patients on dialysis, very important. Patients on dialysis. Chronic kidney disease patient goes to dialysis dependent state. They develop cystic disease. Cystic disease in a normal patient and cystic kidney disease in a dialysis patient. These acquired renal cystic disease in a dialysis patient have very high propensity to develop RCC. So keep in this mind. Patient with dialysis, they are having cystic disease, you have to follow them. Hereditary, well, 2 to 3% are hereditary. We don't go into very details about this, but remember the names. The hereditary papillary, VHL syndrome is very important, but the VHL concept is very important. VHL gene, VHL refers RCC 3 words. This is in chromosome number 3. Short term of chromosome number 3. Done. This is an MCQ. Any mutation, translocation, whatever, will cause decreased production of VHL protein, or known as the PVH. A PVH is the first time I have heard a wild variant of VHL is actually good. Wild things are always bad, but a VHL wild is good. So if there is a genetic mutation at 3P level, VHL protein, the wild variant, is not acting well. What did VHL do? It used to attach to a VHL receptor. It's a tyrosine kinase receptor, and would have prevented the action of activation of HIF-alpha, that is known as the hypoxia inducible factor. Now, if there is a mutation on 3P, this can occur in familial disease 10% and also in sporadic cases. This is the chromosome number you need to understand and you need to keep it in your mind. 3P, done. If the wild VHL protein does not act, there will be upregulation of HIF-alpha, and this will produce excess production of vascular endothelial growth factor, VEGF. This will cause pronounced neovascularity associated with clear cell carcinoma. What is it? Doesn't mean that VHL gene is very important in clear cell carcinoma. It will increase the vascularity, it will give a poor prognosis. So if you can hit at that receptor level, tyrosine kinase inhibitors, that is if you can inhibit the production of HIF-alpha, then there will be decreased production of the VEGF. So this is one concept. Then we come to the histology and the role of renal biopsy. Pathologic subtypes are basically clear cell carcinoma, most common. Then the other concept. You don't have to go through details, just know the names. They may ask you, they become as a theoretical question. Very important, when will you do a renal mass biopsy? If you see a patient has multiple tumors, both kidneys involved, tumors of his spleen, tumors of his stomach, tumor of his pancreas, think if he has disseminated disease, it can be a case of non-Hodgkin's lymphoma, B-cell variety. So if a suspicion of lymphoma, don't go for surgery upfront, do a biopsy, go for a chemotherapy. Abscess, metastasis, rule out, so biopsy. Before starting our tyrosine kinase inhibitors and before giving what is known as the radiofrequency, we will come to details, you have to do a renal mass biopsy, because only clear cell carcinomas, they have good prognosis with these treatments. Otherwise, if you find that patient suffering from renal tumor, there is basically no need to go for a mass biopsy. You're diagnosing it on the basis of CT scan itself. You can go jolly well, because even if the patient has, some people may say the patient may have oncocytoma, a benign tumor. You cannot differentiate. I want to take a biopsy and maybe keep it. But I said that the oncocytoma, when it is present, it's very common renal benign tumor. Then it can have even part of renal cell, can degrade to renal cell carcinoma over time and can have focused renal cell carcinoma, which may be missed if you do a single site biopsy. Very important, the patient, if the examiner asks you, what will you do, an FNAC or an FNAB, you say you do a biopsy, not a cytology, because you want to know about the clear cell etiology of this case. Histopathology is important if you take a biopsy. Simple cytology will miss the diagnosis. Staging, very important. T1, 4 centimeter. Why? 4 centimeter is said to be a small renal mass. So below 4 centimeter, in an elderly patient, you can go for what is known as the active surveillance. But young patient, don't go for active surveillance. T2 still confined to the kidney. So try to understand, there is a kidney, there is a renal capsule over it, then there is a perinephric fat, then there is Gerota's fascia, then there is paranephric fat. So when you do a radical nephrectomy, my friend, you're removing the kidney with the whole of the Gerota's fascia, because you don't want to mess with the perinephric fat. If you take the kidney only with keeping the Gerota's fascia intact, like you do for a nephrectomy for benign disease, it has been seen you're missing what is known as the perinephric involvement, which are basically many times missed by a CT scan. And you can also miss by doing a perioperative manual palpation. It can be only detected by your post-operative histopathology section, and if it is present, perinephric fat involvement, perisinus involvement, your upstage the disease. The prognosis gets, so you can see the renal vein invasion and perinephric invasion are almost same. T3 means it becomes a locally advanced, still within the gerota, but still it is locally advanced. So it's either T3B will be extension of the IBC, tumor thrombus below diaphragm and it's above the diaphragm. And IBC wall involvement, you have poor prognostic mark. T4 is beyond the gerotas or it is involving the adrenal by contiguous involvement. Now, what is very important to state that kidney tumors basically compress rather than infiltrate. The pelvic TCC infiltrates, not compress. That's why it is said that the normal reniform pattern will be maintained if a patient has an RCC, but it is totally disarrayed if you have a pelvic TCC because it's compressing the tissue. It is growing but compressing the tissue. Same can happen. It can involve the adrenal by compression. So if it's a very large tumor, specifically large tumor affecting the upper pole or total of the tumor, if you don't see an adrenal on the CT scan, the non-visualization of the ipsilateral adrenal gland, or you see an adrenal enlargement on the CT scan, or during the operation, you palpate the adrenal field to be distinctly features of involvement, you remove the adrenal, but with the specimen, otherwise leave the adrenal. So this is very important when we talk about staging. Now the prognostic factors, go rush through it. Anatomical is the TNM staging. N, right. Nodal involvement is N1 or N0. Fine, done. Nodal involvement present or absent. Prior we had a nodal resection from the crus of the diaphragm to the pelvic inlet or the aortic bifurcation. Now it is said that it's totally not at all indicated. If you feel the involvement of the lymph nodes at the hilum, you dissect it out. Don't go for extensive dissection. Grade is very important and clear cell has a bad etiology. Clinical factors we have talked about in detail about the civil constitutional science. So this is the file-where cancer specific survival. So whenever you see it's T4 or T3, the prognosis goes down. Now this is the few last slide because we'll be discussing in section 2 the next week on the different surgical principles. So if the examiner asks you what will you do in this case, it's better if a large tumor 7 centimeter, just beginning of surgical practice. If you say that I will do a radical nephrectomy of the patient, I will counsel the patient towards radical nephrectomy, then nobody can fail you. Even yes, the examiner may be highly experienced. He will tell I will do a partial nephrectomy. He can because he is experienced enough. In this case, you say I will consult the patient to a radical nephrectomy. And if the patient asks, 45-year-old gentleman who has 6 centimeter tumor, if he asks that what are my other alternatives, you can say you have an alternative of partial nephrectomy. Now about the other techniques, I will come to radical and partial nephrectomy on the next slide before in just 5 minutes. About the other techniques is something called a thermal ablative technique. When I said a tumor less than 4 centimeter, elderly individual doesn't want to have surgery, you can basically burn the tumors under CT scan guidance. Burn or destroy the tumor with ice packs called the cryosurgery or the radiofrequency ablation, but they will act very well only in clear cell etiology. You have to do a renal mass biopsy and then you have to counsel the cardiac. Active surveillance just mentioned in very brief. If the elderly patient don't want to go for surgery, you can do a follow-up CT, fine. Watchful waiting is done. It's out of syllabus in RCC. Targeted therapy will need a whole class, but to understand that this is basically under the gamut of medical oncology. So if you believe that you are on this 3P and VHL protocol, you want to hit it at the immunity level, then you just try to understand there are some drugs called sunitinib, sorafenib. We will discuss it in the next class. That's called targeted therapy, and this can be due at the neoadjuvant setting. Now, chemoradiotherapy, forget about chemoradiotherapy, cisplatinum, whatever, because these tumors are found to have whatever we had this multi-resistant bacteria. It's called a multi-resistant drugs. Multi-resistant protein is multi-resistant to drugs. What happens? Any chemotherapy you give, the protein will pump out the chemotherapy. So basically, it's all BS when you come to treatment with chemotherapy. This I will start in the next class. Right. This is a surgical template. I want to tell you. This is in very quick. If you ask me, then you have to first ligate the artery, decompress the kidney, ligate the vein. This is the renal artery. This is the renal vein. Ligate the artery, ligate the vein, and then you cut the kidney with the ureter. Some people say whole of the ureter. Some people say some part of the ureter. Doesn't matter if you work with RCC. CCC matters because of field change. RCC doesn't matter. Partial nephrectomy, you basically chop out a piece of it, keeping the other part intact. We'll come to the what is RN versus PN later in the next class, which is just the basics I want to say. Thermal ablation, as you see, you put in tines. Tines are basically tubes through which you pass either radio frequency, either cryo, or even high focus ultrasound, and destroy the tumor under CT, real-time CT guide. Small tumors, multifocal tumors, can do it. So this is in nutshell about RCC. I just tried to hit on the basic points. After this class, if you feel that it has enriched you to 1-2%, please, my request to you friends is just go through the textbook once right now. Because after that, whatever I said you will evaporate. There's a lot of info, even if you find it's a big class, but I have to put in a lot of information. After you go to the textbook, immediately, half an hour, request half an hour of your friends, then you will try to register many points which are told you in fleeting ways. Then you write down the points. Then you send me a mail, or you send mail to Dr. Rudhajit Sinha or Shilaji, and we'll compile your answer questions. We will give you a Q&A session that will more enrich you, because one question you will tell you that can be the question of another person. So that's where we learn together. So that's it what I want to say. And before I finish off tonight, I want to give you one task, home task. Right? I always give a home task to students because only then I feel they are energized. At the end, many will be saying, "Arey yaar, kya bole ye doctor sahab kya bol raha tha?" Aisa nahi hai. You whatever you gathered, you go through the theoretical textbook. Write down small notes. Write down your queries. Then only when you discuss it the next time, you will gather. I also will gather more information because I then will go through the books. Don't think that I know everything. Your questions, many of the questions I may not be able to answer right now. I will have to go to the books. I will enrich your knowledge, and then we will discuss together. But friends, before I go off, I will give you one quiz question. Take a snapshot of this picture. If you have a mobile phone, just take a screen share. Think about it. What is the tag? And we'll discuss it the next time. Thank you, my friends. Thank you, sir.
Okay.
Thank you, Dr. Sinha.
Thank you, Dr. Basu. It was a wonderful lecture. I actually learned so many new things. No, it's always good to meet like-minded people who really want to love teaching and is so dedicated towards it. So as Dr. Basu has said, please put in your question.